活动的一个说明。那今天的这个 topic 主要是在讲这个关于 ICA injury 在经鼻内视镜手术发生的时候的一个治疗的处理的原则啊。那待会我们就请李医师来为我们 present 这个 lecture。那我的部分的话，也会把我过去有遇过的这样的一个 ICA injury 的这个 case 的发生的这个的一些 case 的处理的经验，再跟各位分享。那最后的那个 cadaver dissection 的部分，因为也是因为这个技术上的关系，它直播的关系，我们先预录了一小段在 cadaver 上面的 dissection 的 demo 的部分，针对这个 surgical landmark 啊。那大致上是今天的这个活动的介绍不过因为今天其实本来应该是有这个菲律宾的鼻科的学会跟我们的连线，但是这个非常的抱歉我们的 YouTube 的连接设定很有问题，那这个没有办法跟这个 Room 的部分结合的很好所以我想我简单用英语跟他们说明一下，如果有在线上。Okay, welcome. Welcome you join our Taiwan Skull-Based Society Symposium. We know that we have some friends from Philippine, the Philippine Rhinology Society to join this program. So maybe we can start today's lecture. Dr. Lee is a neurosurgeon from the Chimei Hospital from Taiwan. She will present the lecture, and I will present some my case, the ICA injury, and also show some surgical remark by the cadaver dissection. So that maybe we can start our program. The first, we have to also as acknowledgement of the Carstol company and Medtronic company. And here is some skull-based lecture. Actually, it's a workshop. This is held by my hospital, Taipei Veteran General Hospital, and this is all for the neurosurgeon. But this May we have the endonasal UPMC course. This is also welcome for the ENT doctor. And so this is the course we were going to hold in this May. And also the Taiwan Skull-Based Society, we also have our own dissection course. And this year, it will be on July 22 and 23 in Taipei. And this course is very special because we start to dissect by microscope and by endoscope using the two instrument and two cadaver, but to show the same anatomy location. So that this is a very special course. You are also welcome to join. So, okay, Dr. Lee, you may start your lecture. Thank you.
Okay, can everyone hear me all right?
Yes, I start to share my, you can start to share yours. Thank you.
Okay, so you can see my screen, right?
Yes, it's very good.
Okay, so thank you to Dr. Wang for the invitation for this lecture. And because we have happen to have an international audience this evening, we will complete our lectures in English. So today's topic is management of ICA injury in endonasal skull-based surgery. And I'm Dr. Yaolin Li, and I'm a neurosurgeon from Chimei Medical Center in Tainan, Taiwan. So of course, this is a topic for which no surgeon really wants to have a lot of experience at. But in order to do this, we of course have a lot of published articles from high volume center experiences and expert opinion consensus for this topic. So if anyone has any questions regarding the information, feel free to email me below or give any questions at the end of the lecture. So for an ICA injury, it usually is pretty devastating, but for a skull-based surgeon, it's actually not that uncommon because usually they work around the ICA during a skull-based surgery. So for skull-based OPs, they usually occur at around 3 to 8% of the time, whereas in endoscopic endonasal approaches, they generally occur at around 0.2 to 1.4% of the time. And as we extend our approaches further and further, this percentage increases more and more. But with surgeon experience, the more experience a surgeon has, it obviously decreases very much. So an ICA injury usually causes a mortality rate of about 10%, and immediately it can cause stroke or stenosis of the ICA, and at a later date, it might form a pseudoaneurysm or a carotid cavernous fistula. So in the most part, injury of the ICA mostly occurs on the left side, at a ratio of about 1.3 to 1, usually because the surgeon is right-handed and because the scope comes in from the right nostril and usually looks towards the left ICA of the patient. And the most common injury site is actually at the cavernous segment of the ICA, or in Bucelia's classification is at the C4 segment. So usually the idea is to prevent before we try to treat. So an ounce of prevention is worth a pound of cure, right? So there are several checkpoints where we could try to prevent this from happening, especially pre-op and during the operation. So for pre-op assessment, any tumor may cause an invasion, displacement, or encapsulation of the ICA. So usually we try to check during our pre-op assessment of the CT or CTA, and usually in the journals and papers, they offer that chondroid tumors usually have a propensity to displace the ICA, so we probably need to watch out for that. And as for acromegaly and GH tumors, usually they cause more tortuous ICA. And in revision surgery and prior radiotherapy, as well as prior bromocriptine treatment, there tends to be more fibrosis, as well as it sticks to the tumor to the ICA more. So when you do dissection, it's more difficult. And as it happens with age, with increasing age, a patient may also have a more tortuous ICA. So during the operation, aside from navigation assistance, usually we would prefer to have Doppler ultrasound as well, because then you could check your position in case your navigation is off by a few millimeters. As well, the two surgeon four hands technique is very important because you have an extra set of eyes to check for where there might be danger. So the last part, though, is not to lose sight of the goal of the surgery, especially if the tumor encases the ICA. Do you absolutely need to go to the cavernous section of the ICA to remove that last portion if your goal is not the radical resection in that area? So injury usually occurs in a couple of places. The most likely instance is when you remove the bone on top of the sella floor, and when you do the dural incision. And also the second most likely place is when you do the resection for the cavernous sinus extension of the tumor. And the most likely instruments that could cause ICA injury are shown here as the Kerrison punch and the Kerrison rongeur. They do a tearing movement. So anything that causes a tear, these instruments are the most highly likely culprits. And also the microdebrider. Usually we recommend that you don't use the microdebrider inside the sphenoid sinus, and the sharp suction as well. So in terms of the anatomical landmarks for the ICA, I believe Dr. Wang will have a more extensive introduction for this. However, usually the ICA does have a lot of variation in terms of the curves and the tortuosity, but there are a couple of landmarks. So if you do have navigation that might be off by a few millimeters, then you could also use the landmarks available on top of the ICA to guide you during surgery. And this is especially important because, for example, you see the anterior genu here. Sometimes it can point towards the endoscope, but sometimes it can deviate laterally, sideways. And sometimes, like is shown here in this picture, one will point towards your endoscope and another will point laterally. So this is very important. And a couple of the more important anatomical landmarks include the medial optic carotid recess and the lateral, and also the carotid prominence, and for anatomical landmarks that guide your eye towards the ICA, including the median nerve and the eustachian tube. So in order to do a more comprehensive evaluation of a tortuous ICA, Mayfield Clinic actually proposed four different classifications for 4 different typings of the patient's ICA in 2014. And based on Bouthillier's classification, they looked at the C4 bend, which is shown in the yellow arrow here. And this C4 bend, when they measure the angle here, if it's smaller than 80 degrees, then it's type 1. If it's 80 to 100 degrees, it's type 2. If it's more than 100 degrees, it's type 3. And if it's uneven, asymmetrical, then it's type 4. So this paper actually just tells us that for type 1 patients with angles of less than 80 degrees, it causes the increase of tortuosity at the paracellular region, especially near the pituitary gland. So the space between 2 ICAs can tend to squeeze closer together. In fact, there would be no space between the ICA and the pituitary itself. So for these patients, the risk is actually very high. And the type 2 and type 3 is less so, because as you can see here, with increasing obtuse angle of the C4 bend, you get a greater space in between the pituitary and the ICA. So in the case that you actually do have an ICA tear, then there are things that actually work more than other things. So these are the things that work in order of importance. So the first one is actually the crushed muscle patch. Packing with the muscle patch. Actually, we encourage that you crush the muscle patch with an instrument before you place them onto the injury itself, because the crushed muscle releases calcium, and calcium, as you know, in the classic coagulation cascade, is a cofactor of factor 9A and 10A, and also stabilizes the clot by cross-linking with fibrin. So it's actually an excellent way to tamponade, and it helps you preserve the vessel itself. And muscles that work usually come from anywhere, the SCM, thigh muscle, rectus abdominis, temporalis, and longus capitis. So the second thing that could work is the bipolar coagulation. So if you have perhaps a perforation that is around smaller than 2 to 3 millimeters, then you could attempt to coagulate it with a bipolar. However, once you bipolared it and it's coagulated, then you have to think about packing that still with muscle patch, or in addition, nasal septal flap, because you risk exposure of the artery and rebleeding from that site. And also there's an increased risk of pseudoaneurysm, so you have to follow that up with endovascular treatment. So the next thing is the most common thing that you have in the OR, which is cottonoids, fat, hemostatic sponge collagen. So usually we pack it first with cottonoid, and we if we can, we switch it out for a muscle patch. So the consensus is if you can't find anything first, you tamponade it with a cottonoid and then try to switch it with a muscle patch later. And endovascular treatment is vital for post-operative evaluation. Even if you wanted to see if there is a pseudoaneurysm, or if you need to occlude it if it's doing an active extravasation at the moment. And if it's partial stenosis, you can consider a stent or an intraoperative. There are other things that work, such as an IOM, which is intraoperative monitoring. If you think that you will be dissecting and injuring or occluding the ICA, then it's good to have SSEP monitoring during the operation so that you can monitor if and when you have an occluded ICA and you want to see if there's severe hypoperfusion. So things that are more difficult during the moment to complete are things like direct suturing. This is less likely because there's usually a poor angle, and the act of trying to suture is usually will cause a tear. And so the act of direct suturing is usually too slow and the patient might bleed out. And in the current literature, there hasn't been any successful attempts thus far. And the ECA-ICA bypass can be considered, but usually will be placed later on as an option if you think that an ICA occluded instance will require a bypass in the case of a failed balloon occlusion test. So an aneurysm clipping might work, but is inconvenient because you would need a flexible endonasal clip applier and a sufficient angle in order to maneuver. However, the aneurysm clip might be required in a very large tear because you might need that in order to tamponade or occlude something that bleeds very profusely. It's just very difficult to do at the moment. So flowable gel foam, such as Surgifoam, FlowSeal, or Surgiflow, actually is usually flushed away by the profuse bleeding, so it doesn't work that much. So these are the things that don't work so much at the moment. And Dr. Gardner actually in 2016 offered a management breakdown for ICA injury, and he broke it down into 3 different parts. The first one is assessment, and the next one is treatment, and the last one is endovascular treatment. And the first one is to try and find out whether or not your tumor has a circumferential ICA involvement. And if it does, do you need to do a radical resection? And if so, you might need to consider a balloon test occlusion test. And if it fails, then you might need to perform a bypass or reconsider your goals of surgery. And secondly, in the event that during endoscopic endonasal surgery, you do get an ICA injury, then depending on the size of the injury, you might have to attempt to salvage with a bipolar or an aneurysm clip, or if it's larger, then you might have to consider occlusion, muscle packing, and so on. And regardless of what you do, you would have to still do an angiogram post-op. And for an angiogram, if the vessel is intact, then it's suggested that you repeat the angiogram within 1 week and then follow up with vascular studies in 3 to 4 weeks. And for immediate angiogram, if there is a pseudoaneurysm or active extravasation, then you would have to consider coil occlusion or stent placement. And for these cases, you might need CT or MR perfusion scans to show you whether or not there are severe perfusion deficits in order for you to do a bypass. And for the post-injury endovascular evaluation, it's recommended that aside from 2 endovascular evaluations, one immediately and the next one 3 to 5 days post-op, usually another evaluation, whether by imaging or by golden standard, the angiogram within 1, 3, and 6 months would be recommended because of the possibility of a pseudoaneurysm formation. And usually in 80 to 87% of patients, most of them will tolerate the loss of 1 ICA. So it is possible if you have difficulty trying to stop the bleeding, to try and just attempt to stop it by occlusion, and then most of them can actually tolerate it well. So this last part is just to just zoom in on the key importance of endovascular evaluation. In fact, if there is an active extravasation, you might not always see it under the endoscope. So they can help you to occlude or to do a flow diversion or to place a stent. And if there is critical stenosis, it needs to be followed up and treated. So I think that's about it. And these are my references. Is there any question? I think your mic is off.
Okay. Yeah, thank you, Dr. Lee. This is a very beautiful, comprehensive review of the article about the ICA injury. Dr. Lee is a young neurosurgeon and endoscopy surgeon in Taiwan. From her lecture, probably you cannot believe she may not have so many experience in the very advanced skull-based surgery, but I believe for her, if she, Dr. Lee, have you ever experienced the ICA injury in endoscopy surgery?
No, not yet. Oh, no, hopefully never. Yes.
Yeah. Yeah, but you can. But I believe if you experience such a terrible condition, your brain, you know the step by step how to work out, how to solve this problem. So that's why I encourage her to review this topic, and she did do a very good job. And so thank you, Dr. Lee. And the next part, I will present my case and also show some anatomy dissection work. But Dr. Lee, you can join the discussion at any time. Okay.
Okay. Thank you very much.
Yeah, and so from the view, and I saw our president, Professor Lee, is online. The Professor Lee， 李教授有听到吗？
有听得到，谢谢。
OK， 李教授，抱歉，因为我今天那个YouTube 的连接这个设定的不是很好，跟这个 Room 的部分，我们想说让这个大家能够参与讨论，所以想用 Room， 没想到弄巧成没有设定的很好，所以
没有关系，刚开始都这样。
对那因为线上有那个刚好有菲律宾的鼻科的学会，他们有很多朋友刚好也知道我们讯息，所以他们加入我们这个活动。所以呢，我让大家让那个姚玲用英文来 present。那
OK， 没问题。
那理事长是不是跟我们致辞一下？抱歉，那个
好啊。谢谢李医师跟伟新哦，这个很好的一个那个题目。其实 ICA injury 不管是 open 或是 endoscope， 对外科医师来讲都是一个 nightmare 哦。那处理的方法就好像刚才主任这样子，第一个就是 packing， 然后尽快，以前的方法是 packing 止血以后再想办法做 bypass， 的话是那个 packing 以后再用 endovascular。那我很高兴那个伟新你可以提供这种 这种实战的经验的那个 case 出来，因为这个真的是有时候它那个很 tortuous， 它血管壁万一很薄的话，碰到的时候是很危险的。这真的是 endoscope 会死在 table 上的，就是这种 case 哦。所以我想这个题目对我们颅底的不管 ENT 或者是神经外科都是很重要的。那谢谢你提供这个题目。
Okay， 谢谢李教授，谢谢。Okay, yeah, this is our President Lee is speaking, and so the next part, I would like to present my case and to share my experience. Hope you will not meet forever. Let me share. Sorry. Sorry, let me find out my PowerPoint. Maybe here. Can you read it? Can you see this? 可以看得到吗？哦 ，OK，
看得到。
应该可以。OK， 抱歉，线上的问题就是大概我都搞不清楚这个，大家看得到。So the next part, because Dr. Lee already reviewed a very comprehensive the literature, and so I would like to show my case. Actually, the ICA injury, the incident is very low. In my hospital, my team, we do have the ICA injury, but the less than 1% it happened. But arterial injury, sometimes the condition is the same as the ICA injury. So the step how to solve this problem, I think is almost the same. For the tumor type, for me, I think the meningioma is a very difficult one because this tumor it may encircle the ICA and with the narrowing of the vessel. So and also the vessel already be invasion by the tumor. So this is a very terrible tumor. If from the pre-op image you already notice this tumor, the ICA already been encased by the meningioma. You have to be very careful, and you have better to read the image carefully about the shape of the ICA is narrowing or is not the same type, the normal type. If that in that case, you have to be very careful. And for the pituitary adenoma, I think that this is a relatively benign situation, and very late the pituitary adenoma will encircle the invention of the ICA itself. It probably just encircle the ICA, but the tumor is soft and it may not destroy the wall of the ICA. And for the chondroid tumor like the chordoma, because it already destroyed the bone structure, so the ICA usually be depressed significantly, and so that it also has the high risk of to have the ICA injury. The first case, because I only have the 2 cases of the ICA injury, so there's not much experience. But for me, when I in Pittsburgh, I did 2 or 3 cases. How Dr. Garner to solve this ICA injury. So at the time, I know if I meet this condition, and I will think about how to do if I meet this. So when you do more surgery, and it will happen, especially when you do more aggressive surgery. This is a case of the chordoma, and it's actually is not a fresh case. It's a recurrent one. And I show the number. That's in the very beginning, my practice. Actually, this is not good for the beginner to do this complex surgery. But you know, so sometimes you have to face this condition because maybe only you can have the experience to do the endonasal surgery. This case, you can see from the image point, it's very difficult. The Dr. Lee already showed us the different segment of the ICA. So from the image point, of course, you can to predict where is your ICA. So the paracardium is here, and the next we go to the cavernous sinus. Still, you can see the ICA, and because this is a chondroid tumor, the chordoma, and actually the clival bone already be eroded, and so the problem is the most difficult challenging position is the lacerum ICA, because that's the ICA turning to the petrous bone, and I believe that this lacerum ICA always the very challenging position for the chordoma if the tumor embedded to the clivus like this. So we have to it's better for you to know where is the ICA and try to image the tumor, the location related to the ICA. But this is a very beginning for my practice, and I believe I still remember this case. We have the very long surgery and almost to the midline, so in the end of the surgery, we already tried to do the reconstruction, and my fellow is harvest the fascia lata, and then we just to pack. And what happened, because there's what happened at that time, I just using the suction cautery, try to do the hemostasis, but when if you not very concentrate on where you are, and this will happen. And I just using the suction cautery, and I touched the lacerum, the segment of ICA, because I use a Doppler to detect this location more than 100 times during the surgery. But in the end of the surgery, I do this very the big mistake. So what happened, I didn't record it because we did not record it during the reconstruction. But when the ICA injury happened, the situation is like this. This is the left side, lacerum ICA, because I know what I did using the suction cautery to touch the wall of the ICA. And the wall, because it's a recurrent one, and so it's very fragile, so that it starts to bleed. And so the first step, all you can do is using the cotton to compress. And I have ever saw the Dr. Garner using this aneurysm clip try to trap the vessel wall. But I in the very beginning, in beginning, I decided to try this. And this is my first time to using the aneurysm clip, try to stop this bleeding. But it's a very difficult one, because you can see, as Dr. Lee say this vessel is tortuous, and it turns the position, and for the endoscopic to try this aneurysm clip is very difficult. So it failed. It get worse because I created another wall of the on ICA, and so the Dr. Lam, my partner, she had ever studied in the Professor P.J. Woma in Australia, and P.J. Woma provide this muscle patch technique to stop the ICA bleeding from the ship model, and it works. So she remind me, Dr. Len remind me, maybe we should not try to using the suction cutter as the bipolar or the aneurysm again, and maybe we just the pack with the muscle patch. You see, we harvest the muscle patch from the patient's side, and as Dr. Lee say, there's some technique that published in the paper. You have to crush the muscle, and because the muscle crush, it can release the calcium, and you will help the hemostasis mechanism. So the pack, you have this muscle patch, and you just put on the defect side, and you use the cottonoid and try to a little bit compress, but you cannot compress too hard because you will stop the flow of ICA inside. So almost around the 10 minutes, you can see how it works. The muscle patch, it did stop this the breathing and like this. So this is my I think this is my first case to meet the ICA, and this is as I say that it was in the midnight, and I wake up all the night because I was shocked. And so after the surgery, we did control this situation, but as Dr. Lee say, you have to do the endovascular examination, no matter using a DSA or the CTA. And this is immediate post-op the DSA we did. You can see there's no pseudoaneurysm at that time, and we follow this case, and this muscle patch still work very well, and there's no pseudoaneurysm noted later. And this is another case, the sinonasal tumor, and actually, let me see. Actually, this is not my case. This is my ENT fellow, ENT colleague. He tried to do the biopsy of the tumor because the tumor occupied the sphenoid sinus. But his surgical goal is not to remove all the tumor, but just to do the biopsy to prove what's tumor's pathology. But what happened to him? You can see this is the rostrum here is the right side nostril, and he just using the suction elevator and try to do some dissect, and he go deep into the ostium of the sphenoid sinus, and there's the very fast flow of the blood coming out. And at that time I was not on the table, and he called me to check and for help. And so when I the first thing I do, of course, try to remove the open the sphenoid sinus, and also to remove part of the tumor as soon as possible, and try to see what happened to him. So as the video you see, there's the defect from the ICA. So this is the ICA injury. So this case because it was not expected to happen, but it happened. We do not try to remove all the tumor, but just quick to stop the bleeding. So what I decided to do is I didn't try anything. I just using the muscle patch again, and using the same technique, and to again stop the bleeding again. So we pack another more robust muscle patch again into the sphenoid sinus, and to stop to finish this surgery. And this case again it works again, and so there's no pseudoaneurysm after the surgery. And this is another case. The last case I met with the ICA injury, and actually is the trigeminal schwannoma. And this is around 100 EEA procedure I did. What happened to this case? You can see we already removed part of tumor, but just using the dissector, caudal elevator, try to figure out the boundary of the tumor, and I just push the tumor a little bit, and there's the brine coming out, And this is not like the perforator, the small artery, because the flow is very fast. And this position I know is very close to the paracardial ICA and the lateral ICA. As you can see, the bone already been eroded. So the again, what I did is because at that time I cannot see the defect side. So the first thing that you have to you have to do is try to see where is your defect site. So I using the microdebrider to remove the tumor. I use one suction to compress the defect, stop the bleeding, and to using like this, using the microdebrider to remove the tumor as fast as I can. And then I finally saw the defect site, and I using the muscle patch again to pack on the defect site directly. You have to know, if you find out the defect site, you just using anything to pack, and it will not work. Only the direct muscle patch on the defect work, and it can work. So this is how we did. We're using the nasal flap to cover on the defect and to stop to finish this surgery. But for this case, it's not so lucky like the previous one. You can see from the immediate post-op DSA, you can see here is a pseudoaneurysm noted, and the mean this is still the leak of the blood is still some problem, because he's a young man, and although we also do the balloon occlusion test, and it passed, but the family will not prefer to have using the cover stent instead of to occlude the ICA. So we put the cover stent on the inside the defect wall, and the patient still follow up, and it works well. And this is the post-op image. The tumor resect is favorable, and what happen is here. This is the lateral ICA, and that's the defect site. So from the pre-op image, you can see the ICA, the wall is very narrow. So if you see this image, you have to keep in mind this is a very dangerous one. And so because maybe I'm not so experienced at that time, so I try to mobilize to dissect this wall, and then just a little bit push the tumor, and there's some tear of the vessel wall, so it could happen. So that's my limited experience, but it's very terrible, and I hope that you will never meet this the ICA injury. So because the next part, the final part, I would like to show some dissection work about the landmark, because Dr. Lee already described the very detail of the landmark. So maybe I can go a little bit fast. And the first segment, the paracardial ICA, this is a very superficial one. And this is the most common. You may have the ICA injury, especially for an ENT surgeon. If you're using the Carrison Ronjo and you're using try to punch here, and because of this, the vessel wall is not the flat in the plane, so that you may have the ICA injury here. So how to localize the paracardial ICA is very important. And the next segment is a cavernous ICA. Cavernous sinus ICA, actually, I personally think most people will not have the injury at this part, because when you try to go into the cavernous sinus, actually, you must be very experienced one, and unless you open a cavernous sinus, or you may not to meet this ICA directly. And the next part is the paracardial ICA, and this is also the very common injury site, because if the patient is spinal sinus is not very pneumatized, when you do some drilling or you may have the injury at this point. Lacerum ICA, as I said, this is a turning point for that's a chondroid tumor. This is a very difficult one, and it's a very easy to have the injury because you have to localize the direction of the ICA. So the lacerum ICA is very difficult. For petrous ICA, I believe it's also rarely people will have the ICA injury at this point, at this site, unless this is the nasopharyngeal cancer patient who had ever accept radiosurgery and with some osteomyelitis, and you want to do the surgery for that, and that may make you have the risk to have the ICA injury in this segment. The next is a parapharyngeal ICA. The same for neurosurgeon, we rarely go to this part. And if you do have the nasopharyngectomy, like an PC case, still the parapharyngeal ICA is a problem for you. So for the paracardial ICA, the first part, the landmark, I would say is the lateral OCR and the medial OCR, and also the middle cardiac process. The lateral OCR, the lateral OCR, it represents the same location. When you look at from the transcranial view, it's the same anatomy location of the optic strut. So here is the lateral OCR. Lateral OCR means the recess between the optic nerve and the clinoid segment of ICA of the lateral side. So it's a lateral OCR. And the next, the landmark is the medial OCR. The actual medial OCR is the lateral end of the tuberculum sella because you go laterally, you will meet the ICA here. And the other landmark is the middle cardiac process. It may not be can be seen every patient, and but you have to keep in mind these three landmark: the lateral OCR, medial OCR, and middle cardiac process. And why this is important? Because from anatomy location, if you have this imaging line above the lateral OCR and from the superior end of the middle cardiac process, you can have this the distal ring, and the proximal ring is from the inferior end of optic strut, the lateral OCR, and to connect to the middle cardiac process. So between this two ring, and this is a paracardial ICA. So I will try to localize the lateral OCR in each case. And if you have the lateral OCR, it provides you the more information about where is the location of the ICA and also the optic canal. The cavernous ICA, as I said, is not easy to expose this part of cavernous ICA, but still, you know, but you will help if you know the location of the cavernous ICA, especially when you do the invasive pituitary adenoma with cavernous sinus invasion. The cavernous sinus ICA, you can divide it into three segments. The first is anterior genu, and the second is a transverse segment, and the next is a vertical segment. The vertical segment will continue to be the paracardial ICA when you go inferiorly. So this is the three segment of the cavernous ICA. And the vascular structure in this part, the perforator, will be the meningeal hypophyseal trunk, and the lateral, that will be the inferior lateral trunk. It supplies the lateral wall of cavernous sinus. So because this is in the cadaver dissection, of course you can mobilize the ICA like this, but in real surgery, it's very difficult for you to do this. And you can see here, this is the roof of cavernous sinus, and it represents the proximal ring as I described previously, and so here's a distal ring. So the lateral cavernous sinus, you can have this view. You have to keep in mind when you try to attack the tumor inside the pituitary edema embedded into the cavernous sinus, and this perforator inferior lateral trunk, you still have to be very careful. If you're just using the dissector to prime to dissect, and you may have the avulsion of the ICA wall in this corner. And the meningeal hypophyseal trunk, medially, you may have the inferior hypophyseal artery, and this is very common when we do a skull-base surgery, because sometimes we have to expose the cavernous sinus and to control this inferior hypophyseal artery, and then we can go further back to the dorsum sella or to remove the posterior clinoid process. So the inferior hypophyseal artery is the medial side from the ICA in the cavernous sinus portion. You have to keep in mind this artery when we do the pituitary surgery. And now there's another branch. You may go down to the chiral dura, and this one is the meningeal branch. And from my experience, this artery on the dura, it is very close to the abductor nerve. The abductor nerve, this segment is the interdural segment. Then the abductor nerve will come out from the dura and to go into the cavernous sinus. So for some chordoma case, when you aggress to pierce the dura, during peeling the dura, sometimes you will meet this artery here, and you have to be careful because you try to calculate, and you may injure the abductor nerve here, and you are careful to control. You may also have the avulsion in this part, and that would be the ICA injury. The parachival ICA, I believe in the very pneumatized spinous sinus, you will not miss it because it's very like the parachival ICA. It can be very superficial, and you can localize very on during your approach. For the parachival ICA, of course, we can use this kyphoresis to localize the ICA, the medial side of the ICA. So if this is not a very pneumatized spinous sinus, what I did is I will drilling the middle kyphus here and extend superiorly to find out the inferior end of the pituitary, the sella flow, and then I will follow this dura turning point, and then I can meet the ICA, the medial side here, and then I know this is the medial limited of the parachival ICA. Then I will know the location of ICA. Of course, you can using the navigation or using the Doppler, but of course, for me, I prefer to see by myself, and that's the importance of your anatomy knowledge. So this is a parachival ICA. For the parachival ICA, the same is very difficult for you to mobilize the ICA like this. But in dissection, maybe you mobilize the parachival ICA laterally, you will expose the pectoral apex here. And as I say, the abductor nerve will go from here and then superior to the pectoral apex, and then that will the dura cavity on it, that will be the Doreno canal, and then you go into the cavernous sinus. This is the view from the 40-degree endoscope, and this is from the visual scope, and I mobilize the parachival ICA a little bit medially, and you will see this very dense soft tissue, and that was the petrolingual ligament here. But in endonasal surgery for us, it's very hard for us to identify this soft tissue. But you know there's something there for tumor surgery. Maybe you know where you are, and that will help. And so probably this is a figure I published in one of my paper. If you have interest, I can provide it. And this is the view of the parachival ICA and related to the posterior compartment of cavernous sinus and abductor nerve. Maybe I can to skip this part. And the next is the lastrum ICA. For the foramen lastrum ICA actually is a very complex anatomy location because we know the foramen lastrum that is not a true foramen with the vessel or nerve passed by. It just composed by the three bone, and the ICA just turn the direction into the petrous bone just above the the lastrum, foramen lastrum. And the foramen lastrum itself is filled with the fibrocartilage inside. So this fibrocartilage adherent with the institution tube and also some muscle on its E-tube there. So there was a very tight adhesion soft tissue in this part. So if you have a tumor in this corner, that will very challenging one. And how to localize the foramen lastrum? I published one paper about the foramen lastrum. It described the very detail about the how to use the landmark to localize the foramen lastrum. Because of the limited time, I think it's very hard for me to describe this complex location for you. But the most important landmark, that will be the median nerve, because you follow the median nerve, when you go posteriorly, you will reach the lastrum ICA. So the median nerve is usually the very constant landmark for you. You will not miss it. This median nerve, median canal. But of course, in the paper, we also provide the ligament pterygosphenoid fissure that will also direct to the lastrum ICA. If you have this pterygosphenoid fissure, the ligament, and you have the median nerve, these two lines will help you to direct to point the lastrum ICA. That's how I use. So the next that will be a petrous ICA. But as I say, you have to expose very much to remove the structure before the petrous bone, and that include the maybe the E-tube and also the pterygoid muscle, and then you have to drill in the bone of the petrous bone, and then you may meet the V3, and then you can expose the petrous ICA. It's very difficult for us just want to expose this petrous ICA, but in the case of the NPC or the tumor already destroyed this structure, is another story. So the median nerve always it also help for us to localize petrous ICA, because it shows us where is the lastrum ICA. When you know the lastrum ICA, you can predict the vessel will go laterally and posteriorly into the petrous, and you can predict the direction of the ICA, of course. And also the median nerve, when you go very deep, that will be connected to it will connected with the great petrosal nerve, and then it will just do lateral a little bit laterally to the petrous ICA. For the parapharyngeal ICA, actually I have to honestly, I have no very constant landmark for this part. But for me, the E-tube is over the superficial. I have to identify, and then the V3, the foramen ovale, the V3 coming out, and that can also help me to predict the depth of the parapharyngeal ICA. So just a very quick review about the surgical landmark of the different segment of ICA, and because in the beginning I want to do the dissect by myself in this meeting, but I think maybe I have not so much time, so I recorded the previous dissection cadaver head. Before I go to the next part, I want to show you this machine. There's a product from the Karl Stoll's And actually, this is a portable endoscope compact. It provides the image, of course, the screen, and you provide the light source, and it is a full HD. You can record it, so it's very convenient for you if you cannot buy the the very the expensive endoscope, and maybe this is one for you. You can consider this product, and also it's very good for in the skull-based lab practice. So this is the next the image I was using this this is a portable scope to recording. So this is a cadaver head, and this is a right nostril, inferior turbinate. So we are going to the deep because this is already the head, or I already dissect, so everything is exposure. But the first to localize the where we are, of course, the corona, and then you can know that this is the flow of the spinal sinus. You can see here is the paratovaginal artery, and here is some branch coming out from the pterygopalatine fossa and spinal palatine artery, and then you can know here that would be the median nerve. You will be, and you have the median nerve. Of course, you can follow the median canal and go very deep. And if this is not the very pneumatite or the patient, you can predict the dystrom very quickly. And here is a pituitary fossa, pituitary gland, and I show you here is the lateral OCR. Of course, this is a very pneumatized one. It's very easy to find it, and the superior to the pituitary fossa, here is the tuberculum sella, and lateral tuberculum sella, here is the medial OCR. So you can see here the very beautiful distal ring is here from distal from the medial OCR connected to the lateral OCR here, and the next dual ring is here. Is from the inferior end of the lateral OCR. You can see because the cavernous dura will be removed. You can see the dura with a very tight adhesion on the ICA, and that will be the proximal ring, and you will connect it with the middle canal process. Middle canal process will be removed here. So we know that this is a paracanal ICA, and here this is the cavernous sinus ICA. So if you really want to expose the ICA, cavernous sinus ICA, sometimes you have to with this exposure. So it's not very common for our daily practice. For the lateral cavernous sinus compartment, I just show you the cranial nerve. You can see here. Here is the oculomotor nerve. Here, this one is I'm using the dissector to show you this is a abductor nerve, and just laterally to the abductor nerve, that will be the V1, the first branch of the trigeminal nerve here. And here, and just a little bit superiorly, that would be the trochlear nerve here. And so this is a lateral compartment of the cavernous sinus. But most of the time, when we will see this view, that will be created by the tumor. Most pathology I made is, of course, the pituitary adenoma. The next part, we will move the more inferiorly. That will be the sorry. So just to show you the relationship with the V2 with the foramen rotundum here. We know the V2 actually is not belong to the cavernous sinus, so you can see the very clear anatomy location that limited the boundary of the cavernous sinus. And here, this bone is dorsum sella. We just described the kyphoresis. If you cannot see this view like this, and you have to create this view. So you have to keep in mind the parakyphal ICA, the relationship with this kyphoresis if you follow the dura from the medial to laterally, and you will have this turning point, and then you will have the to localize the paracable ICA medially. And right now, I'm just to mobilize a little bit the lateral side of the paracable ICA, and that would be the petrolingual ligament, because this is a very well dissected specimen, so you can see here. The other side, the left side, this paracable did not dissect like the right side, so you can see here there's a bone medial covering the bone covering on the medial side of the paracable ICA. So again, if you follow this kyphoresis, you can localize the medial side of paracable ICA, and the lateral side would be the lingual process, and that would be represent the wall between the paracable ICA and the Meckel's cave. And here is the median nerve, because this is the specimen I already completed the nasopharyngectomy. So actually the pterygoid process will be drilled away, and so I just preserve the median and just let you see how it go into the deep to indicate the lacerum ICA here. So this is a median canal, median nerve, there's a lacerum ICA, so we can predict the ICA will turn in this point. And this bone chip, as I say, is a lingual process. It's just the landmark to separate the parakyphal ICA and the Meckel's cave. So in when you want to do using the endonasal approach to go into the Meckel's cave, that's a bone you have to remove, and that was a very complex dura fold. You have to understand, and if you know it, and you can using the trajectory. So again, the median nerve go into the deep, and here this the pterygosphenoid fissure, the ligament, as I say, I described in the paper. So with this fissure, and then with this median nerve, and then you will have the lacerum ICA. And the lacerum ICA is show you the next, the ICA turn the direction posteriorly and laterally, and that would be the petrous ICA. So that maybe I'll just go quickly. And, so you can see this is a median nerve, the nasopharyngectomy already done, the E-tube already gone, and we dissect the soft tissue, every soft tissue here, and that indicate the petrous ICA. The next, you will turn another direction. That would be the parapharyngeal ICA. So this is a very deep one in the very deep parapharyngeal space. But superficially, as I say, the foramen ovale for me sometimes I provide me the relationship of the in this corner, and here is the branch of the V3, and I know the medial side, and that would be close to the petrous ICA, and also the petrous ICA. It will not go superficially than the V3, and if you not see the V3, and if you see the V3 and you know the parapharyngeal ICA probably will still in the deep side, but there's some variation of this parapharyngeal ICA. You have to read carefully before the surgery. So I think that this is almost the whole segment of ICA. I did the dissection in the lab, and to show you the location of this landmark, and hope this is useful for you. So I have to apologize again for our technical problem in the beginning because the YouTube link is not work, and I'm just using the room to have this presentation. If you have any question, of course, you are welcome to send me the email. Maybe we can share more information about this knowledge. So thank you for your listening about my lecture. Is there any question from the audience or any question? No? Dr. Lee, you have any question?
A very extensive dissection and very informative cases. I hope I never have to deal with that. But I was wondering, once you place the muscle patch, what do you do afterwards? Do you need to add a glue, or what do you put on top of that?
Yes, for the muscle patch, actually, I never use the glue between the vessel wall and between the muscle patch and the vessel wall, because it is impossible for you to do that. You have to put the muscle directly on the vessel wall. And the next, of course, you can use in the glue, try to make the augmentation of this reconstruction. But the tissue glue, even for the CSF leak, is not the necessary the product you have to use. I think yes.
So in these cases, do you add like a nasal septal flap, or?
Yes, if you have the nasal septal flap, try to complete the reconstruction you want to reconstruct. And because you don't want to go back, if you just pack with the cottonoid, and then you know that's a foreign body, and you have to remove again in the next time, you will never want to face this this wound again. So if you can complete a very a good reconstruction, no matter the nasal septal flap or the mucosal graft, anything without the foreign body, that would be the better, because you don't have to go back again. Just remove and do the reconstruction. And of course, the CSF leak is another problem, because if you already have the CSF leak at a point, you have to complete this reconstruction. Of course, that was even more important. Yes.
Right. Thank you.
All right. I think this is almost time for today's the lecture, and very welcome the friend from the Philippines, and we will have this kind of the virtual symposium or the webinar maybe around 1 or 2 months. There was the same lecture, and if you have interest in, you are very welcome to join us again. And so thank you for all of you to attend this webinar, and hope you have a good night. Okay, can we finish right now? Okay, thank you so much. Thank you. OK， 宇翔，那个我们可以把它那个停止录影，他可以离开了。